Hi there, this is Dr. Zwelling, and welcome to our heart attack and stroke prevention lectures, Limiting Inflammation. This lecture is divided into 4 parts. This is part 1. We're going to talk about cholesterol and a little bit about inflammation. Please march with me through the slides. You may stop this tape at any time. You can go back and revisit any of these slides, or you may call me, of course, and I'll answer any questions. I'll try to go slowly and smoothly and answer any questions as we work through the lecture. Heart attack and stroke prevention is really about inflammation. It's about preventing inflammation. You know, everything in life is about us versus them. In the olden days, it was caveman versus the bear, and I'm afraid the bear usually won. As society came together in larger cities, we had epidemics of inflammation and certainly of horrible diseases. You've read about those, the plague, etc. Sanitation helped bring those things to an end, and once again, humans were able to dominate. Now we talk about things like cancer and immunosuppression, infection, autoimmune disease, and vascular inflammation. At every level, it's about us versus them. When it comes to heart attack and stroke, it's specific to vascular inflammation, inflammation in the blood vessel wall that we don't want to have, that we'd like to get rid of, or more importantly, that we'd like to never have be a part of our life. Hopefully, what we'll describe through these lectures is how we can prevent that inflammation, minimize it, or stop it cold so that we can prevent heart attack and stroke. First, we need to understand cholesterol. As you can see by this slide, the amount of cholesterol that we have in our bodies actually increases our relative risk of heart attack and stroke. You'll see that coronary heart disease, that CHD mortality over time, increases in 3 large male cohorts. The same is true of females. And on the bottom line, on the horizontal graph, what you'll see is the baseline serum cholesterol. In the olden days, we used to look at total cholesterol as the issue. And you may remember everybody talked about getting that cholesterol below 200. Well, that's all old stuff. We're about much more than that now, and this lecture will explore cholesterol, the kinds of cholesterol, and how you can make more good cholesterol and less bad cholesterol. Cholesterol is very important. Don't think that it's not. It is part of our cell wall structure. It's the precursor to many of our hormones, including estrogen and testosterone. And I'm sure there is no one listening or viewing this lecture who doesn't want their estrogen or testosterone. Indeed, it's part of the whole steroid apparatus. Cholesterol is part of a variety of other enzymatic reactions. We must have cholesterol. Cholesterol is made by every single cell in the body. We make about 800 milligrams per day, mostly in cells outside the liver, interestingly enough. The source of most intestinal cholesterol is bile, and that, of course, is the cholesterol that is made by the liver. This is a quick preview of what we do with our cholesterol. Cholesterol is synthesized. We lose some of it in our feces. We make some of it, that's the bile acids that I talked to you about, and of course we have dietary intake. In the end, only about half of the cholesterol that we ingest is really absorbed. The rest is lost in our feces. Indeed, you can have eggs. I know everybody talks about not having eggs, too much cholesterol. Not a big problem. If you want to minimize the cholesterol that you make in the liver and outside the liver, you would generally minimize fats. Eggs are fine. Egg beaters are probably better. Egg whites, even better again if you want to really avoid all of the cholesterol. This is another slide showing the sources of cholesterol. It's a pictorial slide which shows you that bile acids are indeed made in the liver, and the bile acids are excreted into the intestine. The dietary cholesterol also comes into the intestine, and about 50% of all of this leaves in the feces. The rest of the cholesterol does get absorbed. Some of the bile acids are also reabsorbed, as you'll see here in this next slide. Cholesterol is eliminated through the feces. And indeed, there are some drugs that will bind up that cholesterol so that it increases the amount of cholesterol that you lose in your feces, hence making the liver make more bile acid from your cholesterol and distributing less of that cholesterol to all the cells in the body. This is a slide showing the delivery of intestinal cholesterol, and indeed the cholesterol pool, as you can see, goes from the intestine when it's absorbed back into the liver, and the loop is generally continued. Through this next slide, you'll see the hepatic secretion of lipoproteins. When the liver is not making bile, it is otherwise putting cholesterol inside those lipoproteins. What you'll see is that the cholesterol goes into the VLDL molecule, very low density lipoprotein, and those molecules exchange cholesterol with IDL and then with LDL. There are fats that also are stored in those cholesterol molecules, as you'll see soon. Those fats are also delivered to the entire body. That molecule that you see, VLDL, IDL, and LDL, those are molecules that act like suitcases. Inside those molecules are fats and cholesterol. Outside those molecules are receptors that allow that molecule to dissolve in the water-based blood that, of course, goes all over the body. In the next slide, you get a brief look at cholesterol metabolism. As you see on the left, what we eat, it goes into the intestine and it becomes chylomicrons, which go back to the liver. These are big fat molecules. The liver then makes either bile, and that goes out into the intestine, or it makes VLDL, and as you can see, all of those molecules actually exchange cholesterol and fats. The LDL molecule holds mostly cholesterol. Its half-life is longer than the other molecules, and it is smaller than the other molecules, which is why it is considered the bad guy. But all of those molecules, VLDL, IDL, and LDL, as you will see, all can deliver cholesterol to the cells, all can wreak havoc, all can be the source of inflammation. In the next slide, I've tried to summarize this in a pictorial slide where you can see that cholesterol is made in the liver. It goes out into the body. Some cholesterol comes from the intestine. And in the end, of course, the cholesterol that is put into that VLDL molecule is available to cause havoc in any of the extrahepatic cells, or those cells that are not liver cells, anywhere in the body. This is another picture of that cholesterol journey. And what you can see, once again, is that VLDL molecule going out into the periphery. What you see on the right side of that slide is a macrophage. That's a white blood cell. That white blood cell actually eats up that lipid deposit, as you can see, because it assumes that it is foreign. That's the source of the inflammation that we're trying to stop immediately. We're trying to stop that inflammation. We can do that by forcing the liver to make more bile. And we do that, of course, as I said before, with medications that will bind up the bile so that more of the cholesterol is lost in the feces. Certainly we can do that with diet by decreasing the amount of cholesterol that we make so that there are fewer chylomicrons going into the liver. And of course, we can use a variety of medications. Those are not shown here on this slide, but there are many medications that will interfere with this process. Getting back to that LDL molecule, it carries mostly cholesterol. It is the molecule that we measure that we think is the biggest culprit and the major issue when it comes to inflammation inside our blood vessel wall. The liver is the principal remover of cholesterol. It picks it up from the bloodstream. LDL molecule also transfers cholesterol to the HDL molecule. And depending upon your current state of affairs, if you will, we can actually upregulate the LDL receptor on the liver. In other words, we can ask the liver to do a bigger and better job. We can ask the liver to take up more cholesterol. That's called upregulation. This is another picture of the total cholesterol. As you know, total cholesterol is not just LDL. It is LDL, HDL, triglycerides, and it's also all those other molecules. You don't see that in this picture. For the most part, the LDL molecules you'll see here is mostly laden with cholesterol. The high-density lipoprotein HDL is a very small molecule in general, and it extracts that cholesterol from the LDL, extracts that cholesterol from the inflammatory cell, from that macrophage, delivers it back to the liver, and is thought to be the protector. The protein ApoB is a protein that exists on every one of those, I'll call them yucky cholesterol molecules. ApoB is on VLDL, ApoB is on LDL, ApoB is on IDL, and all of the varieties of atherogenic products. There is a single ApoB molecule on every single cholesterol molecule or cholesterol lipoprotein molecule excepting HDL. That being the case, we think that by adding up all those ApoB molecules, we can actually get a better idea of how many of the atherogenic molecules are circulating in our blood system. We think that this might actually be a better predictor of heart disease. In other words, it's not just the LDL, even though it lasts longer, even though it's a small molecule and can get inside that blood vessel wall. Perhaps we need to count all of the bad stuff if we're really going to get an idea of what our real risk is. This slide shows us that the LDL particle number is actually probably a better predictor of disease. What you can see here is that just by measuring LDL doesn't seem to be enough if we actually measure the amount of molecules, and that is of course the horizontal that is presented in the horizontal line. What you can see is that there's still heart disease even when that LDL is less than 70. That's on the graph, the lower graph. So some people with an LDL less than 70 still have lots and lots of those atherogenic molecules, meaning that just monitoring and measuring the LDL may not be enough to actually demonstrate that you've eliminated risk either with lifestyle change or with medication. So this particle number, the LDL-P, is probably a better predictor, particularly in people who have metabolic syndrome and diabetes. They seem to have a lot of that VLDL, a lot of the IDL. And in fact, if you measure LDL in many diabetics, you'd be surprised the number is normal. But we do know that diabetics have a huge increased risk. Whether that's because that LDL particle number is really larger than we anticipate, or perhaps it's because the diabetic often has low HDL or a small number of rescue molecules. But in any event, LDL particle number may be a better means of determining what your risk is. This next slide is also a slide that shows the demonstration that the LDL particle number may be a better indicator of risk than just the LDL concentration. And you can see by the line the probability of event-free survival is really much greater when you have both LDL-P and low LDL-C. Just because you have a low LDL-C, if you have a high LDL-P, in other words, a high number of particles, that's the lowest line in this graph. And you can see that there's a substantial difference in the risk of those people who have low LDL-C and high LDL-P versus those with low LDL-C and low LDL-P. We measure both here, of course, at Choice Care. The ApoB is a good surrogate number for the number of LDL-P, in other words, the amount of molecules, because as I said, the ApoB is exclusive on all of those atherogenic molecules, and there's one ApoB on every single, call them bad or yucky molecules. So this is a good means of measuring, and we measure that here at the office. The point is this: we can do better. And in this last slide, this was the Neptune study, even on those with treatment, many very high-risk patients don't even get to goal. That's really sad. Now, what is goal? How low should your LDL be? Well, that's a good question. When we look at primates other than humans, those who don't have a lot of heart disease, we know that their LDL is as low as 50. They don't have LDLs of 200, 150, 160 like humans have. So I think in general, we believe that that LDL needs to be as low as possible, perhaps as low as 70. Some people begin to have symptoms when it's that low. Some people begin to lose their hair because the cholesterol is part of that waxy substance that makes your hair have a little bit of oil at the base. Some people note that their skin gets a little dry because, again, cholesterol tends to be that waxy substance, that fatty substance that keeps our skin nice and smooth. That said, you always have to weigh risk and benefit, and it's obviously the patient's decision how low they're willing to accept their low LDL cholesterol. In the end, however, it's not just low LDL, as I've stated. We need to absolutely measure the number of molecules, the ApoB or the LDLP. Clearly, we have a long way to go. And as you can see in this next slide, and I'm embarrassed to say this, but our Medicaid population is really not very well served. Even looking at LDL with an LDL of 100, the number of patients not achieving goal is huge. In the commercial population, as many as 40%, 45% in the Medicare population, and as much as 60% in the Medicaid population. That, in my opinion, is shameful. Now let's look at these molecules. The first I'd like to show you is the chylomicron structure. As you can see, this is that big molecule that I was talking about that goes from the intestine goes from the intestine to the liver. It's a big fat molecule, and it's got lots and lots and lots of proteins on it. As you can see, it's got protein A, B, C, and E. It goes only from the intestine right to the liver. This picture, worth 1,000 words, I think, is a picture of the LDL molecule. Inside all that orange stuff is just fat and cholesterol, all that yucky stuff we've been talking about. But on the surface, as you can see, there is a phospholipid and what we call unesterified cholesterol, as opposed to inside, it's the cholesterol ester. This is just a fact of chemistry. You don't need to remember that. But what you need to know is that outside of that molecule with those phospholipids, they allow that LDL molecule to dissolve in our blood and to be carried all over the body. The inside is where the cholesterol is stored, and if there's any fat that's being transported, the molecule, as you can see, is kind of like a suitcase. The next slide demonstrates again that basic structure. On the outside is that phospholipid membrane that allows it to dissolve. Inside is the cholesterol ester, triglycerides, and free cholesterol. This next slide demonstrates all of the atherogenic ApoB containing lipoproteins. What you see on the far right are those big chylomicrons and what we call remnant chylomicrons. That's that leftover stuff. Then you have VLDL, LDL, and IDL. And that darker purple compound that's very small is Lp(a). That is a type of cholesterol. People inherit the opportunity to make that type of cholesterol, and quite frankly, not a good thing. That Lp(a) seems to oxidize very, very, very quickly, and that quick oxidation allows it to get inside the blood vessel wall and be a particular harbinger of disease. So we like to get rid of that Lp(a), or we like to lower the LDL substantially to make it less of a risk. These are all the atherogenic molecules containing ApoB. As you'll see in the next slide, the cholesterol eventually becomes inflammation and then plaque. We want that inflammation to go away, or more importantly, we want it to never occur. Certainly, once there is plaque, we'd like to diminish it. More importantly, again, we'd like to prevent it. We think that the cholesterol is a very important place to start. There are a variety of other things that will be involved in inflammation, as you will see, but indeed, this particular lecture is on cholesterol and what we might do to change that process. That concludes part 1 of this series of lectures. If you have any questions, please feel free to call me. What we've shown you here is an array of all of these cholesterol molecules, the bad, the good, bad, and the ugly, if you will. The good, the HDL, the bad, all of those atherogenic molecules, and the real ugly, that being the Lp(a) and too much LDL. I invite you to continue on through. The next lecture and the next part of this series is on atherosclerosis, just too much healing going on. Thanks so much for your time, and once again, you can see this as many times as you want. Stop on any slide, and if you have any questions, please just stop and call me. Thanks so much.